Hi, we're going to do a quick trauma review to round off the trauma section before you start PODOPEDS. Let's start first with some housekeeping. In regards to some questions that we got during class, I wanted to go over a couple of things regarding fixation. So the first thing is just to show the difference between the K-wire or Kirschner wire and the screws. So you can see in this hallux fracture image, these two K-wires look very different from the screw. There's no threads, so that means that this cannot provide any compression. That means this is basically functioning as a splint, holding the fracture together while the patient's bone heals. So remember, this is going to heal by secondary bone healing or endochondral ossification. The other comment I'll make is about cortical versus cancellous screws and the anatomy of a screw. So remember, you'll need to know that as well. So the first thing is that the cortical screws, as you can see here, they have narrower threads. So the thread pitch, or the difference between the two threads, are smaller. And the reason they're smaller is because it needs to be able to grab into bone that is a thinner portion of the overall bone. So then you remember there's a head, and then the part where the screw head meets the threads is called the land. And the reason for that is to allow greater friction between the bone and the screw so that you get a stronger compression. Now you can also see that there's a partially threaded screw on this image also, and that is, in this case, this is a cancellous screw, not because it is partially threaded, but because the thread pitch is wider apart. And that's wider because it's going to be sitting inside bone that is less dense than the cortex. So the other part of this that's going to be important for you is to remember that the runout, or the part of the screw where the threads begin, is the weakest part of the screw. It is easier to break the screw in that location. Okay, so that's some fixation. I also want to mention to you this concept of Perins strain theory. This was kind of mentioned indirectly in your lectures, but I want to make sure that you understand that the amount of movement or strain on the bone will affect the type of bone healing that it has. So if you have less than 2% strain on the bone that's healing, that's considered absolute stability, and you get primary bone healing in that case. On the other side of that is anything greater than 10% strain would be unstable, and that instability will lead to a non-union. So obviously anything greater than 10% is bad, and you're never going to measure exactly what that 10% is, but if you have a non-union, you know that there is significant strain, and that's one of the ways you can determine what happened if a surgery failed. Now, between those two, somewhere between 2 and 10% strain is considered relative stability, and that is where you get secondary bone healing from. So primary bone healing and secondary bone healing are fine. There isn't one preferred over the other, although the original AO theories really were trying to get primary bone healing at all times. Okay, modern fixation now really has us kind of choosing between which fixation method we want. Okay, now pick of the week. So this one is a program or an app for your phone. This is called Hippocrates. And I'm going to suggest that every one of you download this free program to your phone. You will need it during your rotations, especially medicine. So anything that has to do with prescribing medications will be highly useful for this. So Hippocrates does a really good job with looking up medications based on different search parameters. It lets you figure out your what prescriptions you're going to write, dosages, maximum dosages, side effects. This is a great resource that you will use during the rest of your career. Okay, so that's our pick of the week. Okay, so let's talk now about the study materials sheet that I had given you. This was just some extra study materials to sort of help you with some of the topics that have to do with hindfoot and ankle fractures. So the case number one on that review was this acute injury in a 40-year-old male. You can see that there is a fracture on this CT scan. The CT scan is a coronal view, so you can see that that fracture will be running principally in the sagittal plane. So your question here was a diagnosis, and of course this is a talar body fracture, so that's a pretty obvious one. You could tell that it's the talar body because it's right up against the tibia, so you're right in the ankle joint. So that's an intra-articular oblique, non-displaced talar body fracture that is including the mortise of the ankle joint. How would you classify this if that's the case? Well, the Sneppen classification is the correct one, and that is a Sneppen C or sagittal shearing fracture. Okay, so how would you treat this patient in the ER? All the basic components of your trauma evaluation and management occur here. So you need to immobilize this. You want to get rid of edema, pain control. Obviously, this patient is not going to weight bear because if they do, they could cause this to displace, and then you'd elevate. Now, in the long-term treatment of this, does not necessarily need to be fixed because this is a non-displaced fracture. It's oblique, and as long as it hasn't moved or displaced, then you would not need to surgically treat this. You just have the patient non-weight bearing for a matter of 6 to 8 weeks. If you wanted this patient to be able to go through a range of motion earlier, then that would be the point where you might go in and put a couple screws across this to stabilize it, but that is not required. The next one is about classifying this fracture and what arteries might have been damaged. So you can see that the talar head is still articulating with the navicular. The talar rest of the talus, the body, the whole thing has shot out the backside, and there's one structure that's stopping this from going even more posterior, and that's the Achilles tendon. So this has shot out the back, so you know that the subtalar joint and the ankle joint must be dislocated. So if I was going to classify this, I would use the Hawkins classification, and because the subtalar joint is dislocated, the ankle is dislocated, but the TN joint, it remains congruent, then this is a Hawkins 3. Now, what arteries might have been damaged? That would be these three. So artery of the tarsal canal, artery of the sinus tarsi, and the posterior tibial artery could possibly have been damaged. That last one, the posterior tib artery, is damaged possibly because the body of that talus is pushing up against the artery, and that's going to potentially prevent that from flowing, which means that this is a immediate surgical emergency. So 12 weeks later, upon ordering new radiographs, you see the image below, and the question asks you to describe what you see using appropriate terminology. So you can see that this is a confluent sclerotic talus with involvement of the entire bone. You can see that the talonavicular joint is somewhat incongruent, and the rest of this is normal. So the question is, what is going on here? And this is avascular necrosis of the talus. So this is what occurs if you damage the blood supply to the talus, those three arteries we were talking about. You will get this sclerotic appearance. So one of the questions you might receive during your testing is this Hawkins sign, or what is Hawkins sign, and how do I use that to determine the success of patient healing? So this is a picture that I took from Radiopedia, and you can see a very thin radiolucent line just underneath the talar dome. That radiolucent line is Hawkins sign. So it's not the sclerosis, it's the lucency that you see that is the actual Hawkins sign. And what that tells you is that this patient who has been immobilized after their fracture, that because they're immobilized, the blood will flow through the bone and it will start to uh, kind of flush out some of the harder cortical portions of the bone, some of the calcified portions, and you will see lucency. Now, that is different from this image that you just looked at, where this is all sclerotic. And the reason it's sclerotic is because it's become calcified. That is dead bone. So, dead bone will look calcified. All right, so remember that calcified sclerotic appearance is not Hawkins sign. Instead, the radiolucency that you see here is Hawkins sign. And that's a good sign. That's what you want to see after repairing a talar neck fracture. Okay, the next one here, a 50-year-old female was moving a desk at her home when she felt a severe pain in her posterior heel. Classify this fracture using the Essex-Lopresti system. And you can see that this has pretty much one primary kind of line that's transverse along the calcaneus. And the calcaneus is a lot thinner than it is in the kind of dorsal plantar direction. So that's the case. This has to be a joint depression fracture. Okay, next one. The 54-year-old male fell off a ladder while attempting to trim his trees. Yes, this is very common, especially in California. People like to fall off ladders and land on their feet. They think they're doing great, and then they go to the emergency room and see they fractured their heel. So this question is asking you to draw and measure Bowler's angle and the angle of Gissane, and what is their significance in this case. So the yellow angle there is Bowler's angle, and the green is the angle of Gissane. And you remember that Bowler's angle, as Bowler originally measured it, was 30 to 35, and in this class we're saying 20 to 40 is normal. In this case, we measured 16 degrees. So that's lower than normal, which means that this is a joint depression fracture. The angle of Gissane is 160 degrees here, and that's approaching almost 180, like a flat line. So both of those, one has gotten smaller, Bowler's, and the other has gotten larger, angle of Gissane, and those both point to a joint depression calcaneal fracture. So that's your diagnosis there. Okay, let's get into some CTs of the calcaneus. Sanders classification is still pretty difficult, so let's talk through this. So here's a coronal image. We know we can use the Sanders classification because the sustentaculum tali is there and the posterior facet of the subtalar joint. There are two pieces, so that means this has to be a Sanders 2. And that the fracture line is not in the sustentaculum. It's kind of in the middle of the posterior facet. It's not to the lateral side. That makes this a Sanders 2B. So this is the best example of a Sanders 2B I think you're going to see. So you'll know exactly kind of where that middle portion is. All right, so ankle fractures. This was case number 5. They wanted you to classify it using two systems. So remember the instructions I've given you are to start with the Danis-Weber classification and look to see if the fracture starts below the level of the ankle joint line. That's where this one starts, below the level. So that makes this a Danis-Weber A. So if it's a Danis-Weber A, that means it can only be an SAD type of fracture. Okay, so supination adduction. And in this case, there is only the fibula fracture that's there. So this is an SAD1. So remember, there's only SAD1 and 2. If the medial malleolus was fractured, then that would have been the SAD2. Okay. How about this one? This is a CT reconstruction of an ankle fracture, and we've kind of blocked out the rest of the leg and just showing the fibula. So you have a central fibula fracture. It's kind of spiral oblique. How would you classify this one? And this is a fracture that occurs above the level of the ankle joint. So it's a Danis-Weber C. So in this case, it's you can't really see anything else, and it's a little tricky of me to even suggest that you're going to use the Log-Hansen classification for this. But if you have what you think to be a Danis-Weber C, then you know that at least you've fractured the medial malleolus or ruptured the deltoid. You have ruptured the anterior inferior tibiofibular ligament, and then in that order you then fracture the fibula. So that would be at least a 3. I couldn't tell the 4 because I can't see the posterior malleolus. So how would you repair this surgically? And this isn't something I think we spent too much time talking about. So the closer you get to the proximal head of the fibula, that means the closer you get to the common perineal nerve. And so it is outside of the standard practice nowadays to open and reduce that and then fixate it. Because if you damage the common perineal nerve, the patient ends up with a drop foot. That's a poor result. So we indirectly repair these by doing transsyndesmotic screws. So it's typically either one transsyndesmotic screw that goes from the fibula all the way to the medial side of the tibia, and that's 4 quarter-Cs with 1 screw, or you could put 2 screws in and you can do 3 quarter-Cs, so you'd stop in the middle of the tibia. So you have 2 screws with 3 quarter-Cs. Now, because this particular fracture is sort of central, you could fix this primarily, and that would be, a screw, maybe 1 or 2 screws, and a plate as a neutralization plate to prevent the forces from going through that fracture. Okay, now I threw a couple extras in here for your practice. So what I would suggest is hit pause on me for a second and take a look at this and see if you can figure out your classifications. All right, so now you can see that there are 2 fractures. There's a medial malleolus, a lateral malleolus, and actually a very, very difficult to see very small posterior malleolar fracture. So the lateral malleolar fracture, it looks like it starts at the level of the ankle joint and then it runs obliquely in a spiral fashion up the fibula. That makes this a Danis-Weber. That makes this a Danis-Weber B. I think when I had originally looked at this fracture, it looked like it started above. So obviously, if it started above, this was a Danis-Weber C, and that would make this, because there are a medial malleolar fracture and a posterior malfracture, that makes this a Log-Hansen PER4. Now, if I argued, maybe I'd need a CT for this one, but if I argued that this fracture started at the level of the ankle joint, this would be a Danis-Weber B and an SER4. Okay, you can agonize over that one. So here's another one for you. This one starts at the level of the ankle joint. You can see that. So that means that this is a Danis-Weber B. And it's either a it's either an SER or a PAB. And if you take a look at that fracture of the fibula, it is pretty transverse. There's no spiral or twisting component to it. So that makes this a PAB. So that means the fracture first occurred on the medial malleolus. That's the PAB1. Then as the forces continued through this, you have rupture of the AITFL and the PITFL. That would be a 2. And then a PAB3 was the fracture of the fibula. So this then is a Danis-Weber B, PAB3. Okay, so that's pretty much it for today. This is a quick one in comparison to the prior ones I did. Remember to study up. Don't forget about these. You have a few weeks before your exam. Now it's on to podopediatrics.